Good morning everyone. So today's lecture is on preventive orthodontics. So preventive orthodontics are undertaken when the dentition and the occlusion are in normal occlusion. The reason for this early treatment is to guide the teeth or the tooth into normal occlusion or a harmonious relationship. So the intended learning outcomes: at the end of the lecture you will be able to illustrate the various orthodontic prevention methods for incipient malocclusions, define space maintainers, classify space maintainers, describe the indications, the contraindications of removable and fixed space maintainers. Moving on to the definition of preventive orthodontics and interceptive orthodontics. So preventive orthodontics is the action that is taken to preserve the integrity of what appears to be a normal occlusion at a specific time, while interceptive orthodontics is the action that is taken to recognize and eliminate the potential irregularities and malpositions in the developing dentofacial complex. So in a normal arch, there are natural forces which are exerted on the tooth. These forces are the forces of the mastication, force of eruption, force from the tongue, and forces of the lip and buccal mucosa. The force of mastication and the force of eruption, these maintain a constant vertical relationship, while the muscular forces, that is the forces of the tongue, lips, cheek, which tend to limit the buccal, labial or lingual movements of the teeth. Moving on to preventive orthodontics, what are the procedures that are undertaken in preventive orthodontics? The first being the parent education. So parental education is very important, guiding them or informing them about the importance of the primary teeth and the effect on the permanent dentition. Caries control, care of the deciduous dentition, management of ankylosed teeth, maintenance of quadrant-wise tooth shedding time. Check-up for oral habits and habit-breaking appliances if necessary. Occlusal equilibrium if there is any. Occlusal prematurities, extraction of any supernumerary teeth that is needed. Space maintenance, management of deeply locked permanent first molars, and the management of abnormal frenal attachments which can lead to spacing in the teeth. So space maintenance. So what is space maintenance? It's a process of maintaining a space in a given arch which was previously occupied by a tooth or a group of teeth. So the space which is maintained, so basically we give a space maintainer, an appliance. So this is called as a space maintainer. So a space maintainer is a fixed or a removable appliance which is designed to preserve the space created by the premature loss of a primary tooth or a group of teeth. Moving on to the objectives of space maintainer. So as we all know, natural tooth is the best space maintainer. So the tooth preserves the primate space. It also has preservation of the integrity of the dental arches, then preservation of the normal occlusal planes, and it aids in aesthetics and phonetics. So in this video we will be seeing that there is a premature loss of the primary teeth that leads to mesial inclination or tilting of the tooth and hence space loss, which prevents the eruption of the permanent tooth and the tooth is impacted. This is due to this is in cases where a space maintainer has not been given. So what are the factors affecting the planning for a space maintenance? It depends upon the time elapsed since the tooth loss. So the maximum space closure mostly occurs in the first 6 months post extraction. So insertion of an appliance at this point is very critical. So the best approach would be fabrication of the appliance before the extraction and to deliver the appliance on the day or on the appointment of the extraction. It also depends upon the amount of space loss. So the space loss occurs more in the maxilla than in the mandible, and the space loss is seen more if there's premature loss of the primary second molar compared to primary first molar. The permanent mandibular first molar are mesially inclined. Primary mandibular second molar loss before the eruption of the permanent first molar. The space loss is more in younger patients. The dental age of the patient, if the teeth erupts and the tooth has already 3/4 of the root is already developed, regardless of the patient's chronological age, the tooth will erupt soon. The amount of bone covering the unerupted permanent tooth is also important, as 1 mm of bone resorbs in 4 to 6 months. So if the thickness of bone above the permanent tooth bud is more, so it will take more time, and hence a space maintenance or a space maintainer is required. The sequence of eruption of the teeth also plays an important role. So we should observe the relationship of the developing erupting teeth adjacent to the space created due to the untimely loss of a teeth. Even delayed eruption of permanent teeth, in case if there is a retained deciduous teeth or impacted permanent teeth, then it is necessary to extract the primary teeth, construct a space maintainer, and allow the permanent tooth to erupt into its normal position. If there is congenital absence of the permanent tooth, then either the treatment depends, either you hold the space or you close the space. So by hold the space for a fixed replacement or allow the space to close, followed by orthodontic treatment to guide the tooth into the desirable position. So how do we analyze the space that is post extraction? It is space loss is there, or space excess is there, or the patient needs space maintainer or he does not need space maintainer. So we compare the space available with the space required. So we compare and see if the space available is excess, or if the space available is adequate, or if the space available is deficient. So to check the space available in the arch, we do model analysis. So in permanent dentition, the analysis done are Pond's analysis and Ashley-Hose analysis, while in primary dentition it is Huckaba's analysis, Hickson-Oldfather method, Moyer's mixed dentition analysis, Nance analysis, and total space analysis, and Tanaka-Johnston analysis. So in Moyer's mixed dentition analysis, we use a probability chart which is used to predict the size of the unerupted permanent tooth. Here we use the mesodistal width of the mandibular central incisors and lateral incisors. Then the value which is obtained is used in the probability chart. So the probability chart, what you see with the 75 percentile is used. This value gives us the predicted width of the unerupted canines and premolars. The space available is measured using a brass wire extending from the mesial surface of the permanent mandibular first molar on one side to the mesial surface of the mandibular first molar on the other side, opposite side. And this gives the space that is available. So the difference between the space available and the space needed gives the discrepancy. The next we move on to the Huckaba's analysis, which uses both cast of the patient and the radiograph to determine the width of the unerupted tooth. So in this we have a formula which is x is equal to x dash y by y dash. So x is the width of the unerupted permanent tooth, that is the one which we have to find, while x dash is the width of the underlying permanent successor on the X-ray film multiplied by primary tooth on the cast by the width of the primary tooth on the X-ray film, which gives us the value of the width of the unerupted permanent tooth. So the third type of analysis that we do, or in the mixed dentition analysis, is Tanaka-Johnston analysis, where 1/2 of the mesodistal width of the 4 mandibular incisors plus 10.5 gives us the estimated width of the mandibular canine and premolars in one quadrant, while the other formula for the maxillary quadrant is 1/2 of the mesodistal width of the 4 lower incisors plus 11 mm, which provides us with estimated width of the maxillary canines and premolars in one quadrant. Moving on to the indication of space maintainers. Space maintainers are indicated when there is a premature loss of the primary teeth and there are signs of loss of space. If the space maintainer will make future orthodontic treatment less complicated, if the need for the treatment of malocclusion at a later date is not indicated, when the space for a permanent tooth should be maintained for 2 years or longer, to avoid supraeruption of the tooth from the opposing arch, to improve the masticatory system and restore the dental health optimally. The contraindications of space maintainers is when the succedinous tooth is about to erupt soon, when 1/3 of the root of the succedinous tooth already formed, when there is excess space and space loss is not expected, space shows no signs of closing, and there is absence of the succedinous teeth. The ideal requirements of a space maintainer is it should maintain the mesodistal width that needs to be maintained, which was created by a lost tooth, restore the function and prevent the supraeruption of the opposing teeth. It should be simple in construction. It should be strong to withstand the functional forces. It should not exert excessive stress on the adjoining teeth. It should permit maintenance of oral hygiene. It should not restrict any normal growth and development and natural adjustments during the transition from primary to a permanent dentition. So moving on to the classification of space maintainers, there are various classifications. According to Hitchcock, it is removable or fixed or semi-fixed, with bands or without bands space maintainers, functional or non-functional space maintainers, active or passive space maintainers, certain combinations of above. According to Raymond, it is removable, complete arch, maybe lingual arch or extraoral anchorage, individual teeth. Examples of fixed space maintainers are band and loop space maintainers, transpalatal arch space maintainers, transpalatal arch, lingual arch space maintainers, distal shoe, and aesthetic anterior space maintainers. So the removable space maintainers are acrylic partial dentures, full or complete dentures, and removable distal shoe. So first we will be dealing with the removable space maintainers. So these appliances typically used when more than one teeth has been lost in a quadrant, and it can not only the partial denture, it replaces more than one teeth, and it can also replace the functional occlusal function of the jaw. There are drawbacks of the removable appliance is patient compliance is very important, which is not possible in young children, and the retention of the appliance. Here in this picture, as we can see, there are a lot of multiple missing teeth in the patient, both in the maxillary and the mandibular arch, which is replaced by a removable partial denture. This removable partial denture provides the aesthetics and phonetics, especially in the anterior tooth region. The advantage of space or removable space maintainer is it's easy to clean and permit maintenance of the oral hygiene. It maintains or restores the vertical dimension of occlusion. It can be worn part-time, so it allows the blood circulation to the soft tissues, and it can also provide when there is eruption of the permanent tooth, room can be made for the permanent tooth to erupt without changing the whole appliance. It stimulates the eruption of the permanent teeth, and it helps in preventing the development of tongue thrust habit into the extraction space. The disadvantages being it may be broken or lost by the patient. This again is the patient compliance. Uncooperative patient may not wear the appliance. Removable appliance may restrict the lateral jaw growth if clasps are incorporated into it, and it may cause irritation of the underlying soft tissues. The indications of removable space maintainer is when aesthetics is of importance. In case the radiograph reveals that the unerupted permanent tooth is not going to erupt in less than 5 months, if the permanent teeth has not fully erupted and band is difficult to adapt in partially erupted teeth, if there is multiple loss of deciduous teeth which may require functional replacement in the form of either partial or complete dentures. The contraindications being lack of patient cooperation, patient allergic to acrylic material, and epileptic patients. So moving on to the fixed space maintainers. So fixed space maintainers are fixed or fitted onto the tooth or teeth and are called as fixed space maintainers. The advantages over removable space maintainers is bands and crowns are used which require minimum of tooth preparation, does not interfere with the passive eruption of the abutment teeth. The lateral jaw growth is not hampered. The sustenance tooth are free to erupt into the oral cavity, and it can be used in uncooperative patient because patient compliance is not required here. The disadvantages being elaborate instrumentation with expert skills is needed. The bands may result in decalcification of the tooth structure in which the band is applied. There might be supra-eruption of the opposing teeth if Pontics are not used in the space. If Pontics are used, it may prevent the eruption of the permanent tooth and may replace the permanent tooth. So in this video we will be seeing that due to premature loss of the primary teeth, but as in the previous video we saw there was no space maintainer which was given, but in here we will see because of the premature loss of space, a space maintainer is given, so that maintains a space and the tooth erupts into the position, and hence no crowding or malalignment of teeth that we see because of space maintainers. So as we can see here, this is a case scenario which we will be discussing in our Google Classroom. So among both the cases, that is A and B, which case requires a space maintainer, A or B? So as we cannot discuss it, in A what we can see, the primary teeth, the teeth of in the picture A, what we can see, this is the primary teeth, and the first premolars has already erupted, the second premolars is still to erupt. The primary second molar is still there, and the permanent first molar is erupted. So there is no roots that we can see here. So the tooth is soon going to exfoliate, and there is no bone coverage that we see. So as soon as the tooth exfoliates, the permanent tooth will erupt into the oral cavity. So there is no need for a space maintainer in case A. While in case B, as we can see here, there is post extraction, there is space which is here, and the tooth bud, the permanent tooth bud which we see here, there is 1/3 of the root has just started. If we go and if we see the Nolla stages of tooth eruption, the root has all just started to develop. So there are chances of loss of space if we do not give space maintainers. And again, as we can see, the bone, it is more than 3 mm to 4 mm, so this will take again around a longer time for it to erupt. As we know, 1 mm of bone resorbs in 6 months approximately, so this bone what we see here will take a longer time to erupt, and hence there are chances of space loss to occur. So the case B requires a space maintainer, while case A does not require a space maintainer. Thank you. So the discussions will be done at the end of the lecture on preventive orthodontics in the Google Classroom. So I will be uploading few pictures or case scenarios based on it. Thank you.